especially the day of the procedure, and really no scrubbing in the stratum corneum, leaving that intact, and using no acetone or alcohol because this is flammable, so it's important that you don't clean it like you may do with the TCA peel, for example. So treatment principles, you hydrate the skin before. A great use is a topical anesthetic like benzocaine, lidocaine, tetracaine, because you're getting two effects with it, both the hydration as well as the anesthetic. I usually just hydrate for about half an hour, but I think it's somewhere between half an hour to an hour. The reason is that I do a lot of combinations with fat grafting. Most of my before and afters are with fat grafting. It's just a technique that I do. I have a press release coming out with these guys about how to use it with fat grafting. But again, you may be doing it differently than me, so I just disclose that bias that I have. It is flammable, so again, the acetone alcohol is an important thing to avoid, as well as turning off the oxygen. So if you got to remember to do that during the treatments. Protecting the eyelashes. I was going to go through a little video of how to do this, but with Dr. Garcia doing it, that's sort of redundant. But you want to protect the eyelashes. What I usually do is just use a moistened tongue blade, flip the lower lashes up as I treat across that. And then while I'm doing all the areas near the hairline, I use a folded, wet, moistened 4x4. And my assistant helps hold the inferior, I hold the superior, and I just basically trace up and down in a vertical fashion. But the key also is because the energy is actually beginning to it's a high depot of energy. You don't want to snake back and forth like you may do with a CO2. You want to go in a linear tracking fashion, so from, let's say, left to right, not left, right, left, right. Technique, basically, this is again a bit redundant, but some of the elements is after the BLT, sit there, you wipe it off. I really have found a great thing is I like marking all the subunits out like I would do for a TCA peel. The great thing with marking the subunits is that since this is non-chromophore dependent, you can use a black pen. I use an eyebrow crayon because they can wipe off pretty easily, and I'll mark all the subunits out, and I'll actually further subdivide the cheek because the cheek is a massive area, and I just like dividing it either in quadrants or just one across that way, and that just helps me know where I was. And because the thing about this versus CO2 is that you really don't see exactly where you were unless you're dealing with significantly sun-damaged skin. Then you see more this glisten pattern where you were. So to keep me consistent, I mark all the subunits out with an eyebrow pencil. And I start with a low setting at 3 joules. I think it's a safe setting. You don't want to go too high around the eyes. So I do basically a single pass of 3 joules around the eyes. And then 3.5 joules, sometimes double passing at a faster speed at 1.5 hertz. The hertz are just basically how fast you're going. And I found that around the eyes, just being a little bit more slow, a little bit slower at 1 hertz is good, and then going to 1.5 hertz for the rest of the face. In my hands, it's about right. 2 hertz is a little bit too fast for me to control a good outcome, but clearly in your hands it could be different. This is again a relatively early result, about 3 months out, again combined with fat grafting upper left. There's a better texture tone. I always tell my patients that this is not CO2, it's not going to eliminate all the deep rhytids, but it's going to get a nice improvement, texture tone especially, as well as finer wrinkles and some deeper wrinkles as well. And this is about 9 months out, fat grafting upper eyelids and rhytid. These are all high settings, by the way, at 3.5 with a few double passes. And this is a little Botox in the forehead too, but fat grafting and Rhytec, and this is about 9 months out, 9 months out. And this is an interesting use of it. It's a lady that had a CO2 laser with a demarcation on the jawline. I went back and feathered it, and I think it's a little bit softer at 6 months along the jawline after treatment there. So in my practice, how do I use it? I use pixel therapies, fractionate therapies, instead of the PSR1. I'm almost basically always a hybrid PSR2-3 guy, and so I have a bias with that, and my bias is combining most of all my procedures with fat grafting. It's just, to me, it's a great way for me to achieve a better result for a patient, and combining rhytid treatment as well as with volume treatments. And I have combined it with facelifts. If it's more of a limited SMAS dissection, I do both in combination. And I'm pretty much a full face guy, although the nice thing what the company has mentioned, I don't have a lot of experience with it, is that regional treatments are relatively safe in terms of not creating demarcation zones that you may see with more aggressive ablative technology. My take-home points for you today, besides some of the pearls that I may have offered you, is the fact that I really see this as not being the perfect treatment modality for really, really deep rhytids, but in my opinion, given the efficacy and the safety, it's probably out there being much better in that I can treat almost all Fitzpatrick 1 through 3s, whereas with TCAs I really had to hand select my patients for very thin skin to get a great result. If they're getting into the deeper, thicker skins, I just didn't see much change in their appearance, and I really don't have extensive experience with phenol. I think the nice thing about this is it's not cardiotoxic, but it's also the fact that it's very easy with good hands to deliver that. With phenol, I was having a harder time just getting what I wanted to do in a safe fashion. So basically, the other nice thing about it, with the zonothermal modification, you do get ongoing improvement over a period of a year.